Hello, my name is Chris Marchak, and I'd like to talk about what we have learned in our practice about guided surgery in the last 10 years. When patients present, such as Liz here, with a complete maxillary denture and a history of implants being placed, as we evaluate these implants that were done, these implant positions that were stated, having a cone beam CT from our 9300 scanner, we can see truly were these implants where we needed to have the implants placed. Looking at these positions and the surgeon that may have placed these implants, what type of technology could have helped in really understanding these positions of implant placement? Did we get the implants really where we expected them to be? Or maybe it's this patient who presented after a reconstruction no more than 1 month after completion. What went wrong when we see these types of prostheses and look at the restoration? But more importantly, as we see and evaluate the implant positions and placements, taking again a cone beam CAT scan of the implant positions, did the surgeon maximize the use of bone and truly plan the positions for support of that restoration in regards to treatment for this patient? Was technology used to understand where the bone is? That's why I think it's crucial in regards to CT-guided surgeries and using this technology that's out there with cone beam CTs to understand how we can place those implants. So when we look at the past 10 years of the fully edentulous patients, I'd like to speak about what we learned surgically. What are some of the studies and how we can use those studies in accuracy of transferring that implant position to the patient? And why is there a need for a calibration object? And lastly, what did we learn restoratively about these patients? Because as the changes in software programs developed from the very beginning of this guided software to where we are today, it all is based on a historical aspect of understanding what was done and how to use this technology from Van Steenberg's original paper in guided surgeries and looking at what success rates that were done and the ability to transfer those positions to patients. I was very fortunate to begin this journey with Dr. Peter Moy, the oral surgeon that we worked with back in 2002 and 2003 in treating these patients. We have a series of patients that have been treated, of 13 patients, 14 arches. These are just some of the patients that were treated for the completely edentulous arch with a prefabricated prosthesis that was delivered at the time of surgery. When we look at these treatments of these 13 patients, 14 arches, we have a cumulative survival rate of about 92%. So what did we learn surgically? Well, it's crucial about that access. What is the access of implant placement and the trajectory? And we really need to understand which system you're using, the template that is being used, because each system is different when we measure the top of the implant to the top of the template. What is that system and the depth? We have to understand about the XY axis, but how about that Z axis? With Nobel guide templates, these are all pre-measured with their instrumentation of about 10 millimeters, again from the head of the implant to the head of the surgical template. Other systems may vary per implant, so it will vary per size, and we need to make sure that we have the right measurements for that surgical access and trajectory. The occlusal registration is also crucial because remember, the most important part of planning these treatments is that the position the patient is scanned in that centric relation record and the use of the radiographic template has to be duplicated on the patient with the surgical template. Again, the position of the radiographic template and the position of the surgical template must coincide to have greater accuracy, because the position that we plan the implants in the software is the position the radiographic template was placed, and therefore the transfer of the surgical template position is crucial. That is why a surgical index must be fabricated for every patient so that we have that transfer of the position of the surgical template. Remember that with soft tissue or bone templates, these are now flapless procedures. And with flapless procedures, it has become more crucial about access of visualization, access of each implant that is placed. The position or placement of these implants may be simplified, but the actual procedure has become very crucial and being very specific about trajectory, access, height in the XYZ axis, registration of placing each implant in the precise planned position. If you are going to deliver a prosthesis at the time of surgery, it is also critical to understand where those implants lie. If they're seated to apical and there's a crest of bone around the implant, it may be difficult to seat a prosthesis. So therefore, prosthesis design, the bone around the implant, and the head of the implant of access to seat the restoration becomes crucial. These are some video clips of a patient that Dr. Moy and I were treating in which the implant was placed apical to the crest of bone, preventing the seat of the prosthesis. And Dr. Moy is having to clean around each implant with the soft tissue, as well as using a bone mill around each implant so that we have better access for the placement of the prosthesis and having to prevent bone from preventing the seating of the restoration. The other crucial aspect is that when we place the implants, the original protocol was to place one implant at a time, where we placed the first implant one before the most distal position. We found that if we did it in this protocol and the implant was over-torqued, it will also over-torque or move laterally the surgical template. So therefore, we've changed our protocol to actually placing two implants almost at the same time so that we can have passive seating of the surgical template onto the soft tissue. The osteotomy would be created for one implant, then the osteotomy would be created for the other implant on the opposite side. The two implants were placed just before seating of the surgical template or touching the head of the surgical template. And then going from one implant to the other, slightly moving the implant or seating the implant to the correct position in the Z-axis and allowing that to seat simultaneously so there's no torquing or over-torquing of the surgical template. This is a crucial surgical step. So when we look at a comparison between traditional surgical templates versus CAD/CAM surgical templates, does it really make a difference? Well, that was what Cement had looked at back in 2003 when he took 5 surgeons, looked at 5 plastic or epoxy edentulous mandibles. 5 implants were placed with a surgical conventional surgical template on one side and using that radiographic template and planning on the opposite side with a surgical planning software, which was Simplant. 5 surgical templates were created at different sizes for the osteotomy. After the 2 different means of placing implants were done on the edentulous mandible or the epoxy mandibles, these models were then rescanned and looked to compare the differences in implant placement. Whenever there's a comparison of the transfer of what was planned on the patient on the program software versus what was actually placed on the patient, the typical means of measurement is 3 means. One is the distance between the head of the planned implant and the actually placed implant, the distance between the center of the apex of the planned implant versus the actually placed implant, and third, taking the long axis of both implants planned and placed and look at the angular deviation. Well, what did Cement find? He found that in traditional surgical templates versus CAD/CAM templates at the head of the implant, 1.5 millimeters for a traditional surgical template and 0.9 millimeters for a CAD/CAM template. At the apex of the implant, 2.1 millimeters versus 1 millimeter. Degrees of angulation are formed 8 degrees versus 4.5 degrees. They concluded that CAD/CAM surgical templates did allow for improved implant placement versus freehand. But what clinical studies are there? Well, there are very few. This study, which was done in 2005, looked at what was actually planned versus what was placed. They took 4 patients, large sample size of 21 implants. They made radiographic templates that were created for CTs with Simplant and SurgiGuides were fabricated. 3 templates per implant, which corresponded to the different size twist drills that would be used to create the osteotomy. These were used in 2.2, 3.2, and 4 millimeters. They were both bone-borne and tooth-borne surgical templates. After the osteotomy was placed or created, the surgical templates were removed, the implants were placed, and a second CAT scan or cone beam CT was taken. What did they find? Well, at the head of the implant, 2.45 millimeters, but a range of 0.2 to 4.5 millimeters. At the apex, average of 2.9 millimeters, but a range of 0.8 to 7 millimeters. The question is, do you think you're placing that implant where you had planned it? The angular deviation, 7.25, with a range of 3.6 to 12 degrees off. Well, that is where the difference of where Daniel Van Steenberg and Mats Anderson looked at creating a surgical template for the fully edentulous patients with some type of anchorage, creating the osteotomy through the surgical template, and implant placement also was guided through the surgical template. In this study, they actually showed 2 different studies. One was a cadaver study and one was a case studies of 8 patients that were immediately loaded. In the cadaver study, they looked at a completely edentulous maxilla. 10 implants were placed through a Noble Guide surgical protocol and a Noble Guide surgical templates. They took pre and post-op CTs, and what did they find? At the head of the implant, averaged 0.8 millimeters, an average of 0.9 millimeters at the apex, and an angular comparison of about 1.8 degrees. This type of study was repeated for partially edentulous patients with Van Asch. Now Van Asch wanted to evaluate the precision of the transfer in partially edentulous patients. They took 4 partially edentulous cadaver jaws, made pre- and post-op CTs with the surgical planning software Nobel Guide with Nobel Guide surgical templates. The CAD/CAM guided surgical templates were fabricated, and they then also used 10 to 15 millimeter long implants, because the longer the implants, the greater that deviation can be at the apex. Well, they found that an average angular deviation of 2 degrees with a range of 0.7 to 4 degrees. At the hex, a linear deviation of 1.1 millimeters with a range of 0.3 to 2.3 millimeters. And at the apex, an average of 2 millimeters with a range of 0.7 to 2.4 millimeters. They concluded that cone beam images could be used for implant planning, as well as taking into account that we should look for the percentage of error of angular deviation, as well as that amount of error that's possible at the apex. This amount of error can vary depending upon clinician to clinician and system to system, and understanding what that error is for you. But again, there are very few clinical studies. That's why I approached the periodontist that I work with, Dr. Alan Charles, in a patient's treatment. We had the opportunity to look at one patient, large sample size again, where we wanted to know how accurate the implants that were placed. Nobel Biocare had come up with a new technique where they had voxel-related comparison or validation, where we're taking the voxels of the preoperative patient data and the postoperative data after the implants were placed. With this set of data, the voxel-based rigid registration, we would then take that post-op data and make a comparison by adding in the planned data as well as the placed implant data based on voxels. Because it is voxel related, where we have a volume of data or pixels in a volume, and so this is now three-dimensional, we're also able to not only look at the distances between the head of the implants, apex of the implants, and angular deviation, but also depth and change in the depth, height, and variability of the hex. So as we looked at Dr. Charles's work, here's the pre-op data of our patient, the post-op data of this patient with 10 implants placed with the planned implant positions. Taking that voxel information, we're able to remove the patient data. And with the removal of the patient data, we can now make a comparison between the planned implant sites, which were yellow and magenta, compared to the light blue, which is the actual implants placed. These are the actual numbers in those 6 measurements that were completed. And what was interesting is that we could make a comparison between Nell Van Asch and Van Steenberg with their cadaver studies. Implants 4 and 7 seem to be have the most range, and we looked at different averages. So the deviation at the apex, Dr. Charles had an average of 1.25 millimeters with a maximum of 1.8, which actually falls into play with Nell Van Asch and Van Steenberg's work. At the hex, 0.97 millimeters. Maximum was 1.48 millimeters, or 1.5 millimeters. Van Steenberg and Nell Van Asch, 1.1 and 0.8. Again, right, be able to repeat those measurements in those studies. And the angular deviation, 2.7, Nell Van Asch and Van Steenberg, 2 and 1.8. We also had those other measurements of depth, which averaged about 0.63 millimeters. So we were deeper, about an average of 0.63 millimeters, as well as the hex changes of 0.64 and the positioning by 0.61. So what did we learn about this accuracy of placement of the implants from the planned position to the place position? Well, a lot of it has to do with the radiographic guide having to be perfect. We want to simulate tooth position, soft tissue in that edentulous space during the CAT scan, and that the correct design of the radiographic template is fundamental for the success of treatment. And that surgical template is based on the geometry of that radiographic template. Also, the surgical template must be in exactly the same position as the radiographic guide was during the cone beam CT. Again, this is most critical. The surgical template must be in the same position as the radiographic template was during the acquisition of the cone beam data. Having that position and using the right protocol, we need to also have a correct centric relation record. How is the patient binding onto the templates? And a correct radiographic index, because that radiographic index will also transfer positions for the correct surgical index. Again, the position of the radiographic template and the position of the surgical template must coincide and be in that same position for accuracy. Well, what did we learn about these templates? The radiographic template, well, we presume that the surgical templates are exactly the same size, but are they? What's interesting is Lampert Stumple from San Francisco did a very interesting quick little study, and he wanted to look to see if there's any potential for change, volumetric change in the stereolithography process of surgical templates comparing to the radiographic template. He took 3 different patients with possible discrepancies. Here he's taking the radiographic template and made a polyvinyl siloxane putty of the index at the occlusal index. And the duplicate denture that was produced, wow, wasn't the same size. In fact, it was quite far off. He then took the same putty matrix or material and looked at the intaglio surface. Was the intaglio surface different to the duplicate denture? Well, it was slightly off. It wasn't as precise a fit of the intaglio surface of the radiographic template versus the CAD/CAM duplicate denture. He then took a patient and looked at it from a stone index. Maybe it was the materials. But again, the occlusal index to the duplicate denture with a stone index was very far off. Lampert Stumple actually concluded that in the SLA-produced surgical guides, there is a potential to be dissimilar from the original scanning denture. And this will have an effect on the clinical reliability of the surgical guide. And this is probably due to the ISO threshold settings, because it is very sensitive when we produce a surgical template. So some type of verification of the volumetric congruence was advised. And that is why a calibration device should be used. A calibration device that is used not to calibrate the CAT scan, but to calibrate the software so that we have a known size device, a known density, and a known shape, that we can place that into the computer so we can look at the correct ISO values. So if everything is calibrated in the software, we can now produce something that is in the right size. Because if the ISO values are off, such as being too high, that can make a smaller template. Or if the ISO value is too low, it will create a larger template. And this will all affect the seat of the surgical template and the positioning of that surgical template. So a calibration device is crucial in accuracy of implant placement and the fit of these surgical templates. What did we learn restoratively? Well, in many of our patients, we had placed immediate restorations for an immediate load procedure. Initially, these prostheses were fabricated in Europe by Noble Biocare, and they were made out of carbon fiber. And we had many cracks. The problem with carbon fiber is that it is very strong. It doesn't break. In fact, we did not have one carbon fiber framework break, but it flexes. And as it flexes, the acrylic resin veneer around these frameworks did not, and therefore we had multiple fractures, especially fractures right around the implants or implant cylinders, because this was where it was thinnest. Multiple fractures of the veneering acrylic resin. We also had extensive wear of these types of prostheses. Many patients had occluded or weared through the acrylic resin teeth, which then led to fractured teeth, delamination of teeth, and other prosthetic issues of the restorations. Design of the prosthesis is also crucial for hygiene. In those initial days that implants are integrating, that design of the prosthesis is crucial so that patients have access. Any overlap or any overlapping pontics made it difficult for these patients to clean. And so therefore, oral hygiene instruction, use of different aids such as the Salker brush was crucial in helping these patients with soft tissue lesions that were caused because of inability to clean around the prosthesis. And as we looked at immediate load prostheses, probably the biggest factor to consider is the lack of a try-in procedure, because we cannot try in these prostheses. This patient that I treated before and after, and their smile, and what we were able to do, and the change. We really need to consider immediate provisionalization and not definitive restorations. As stated earlier, we treated 13 patients and 14 arches. There were 78 implants placed between 2003 and 2005. We followed up multiple patients, but this is just one of those patients that we had followed up. This patient was treated in 2003, and the mandibular arch was treated first with an immediate load prosthesis. 1 year later, this patient was treated in the maxilla, an immediate load prosthesis, and 1 year post-op. This patient, number 7, began treatment with me having a maxillary denture that was ill-fitting, a mandibular partial denture with periodontally involved teeth on the mandibular arch, and fractured teeth. It was diagnosed that the teeth should be extracted and immediate dentures were fabricated. Using those complete dentures in the maxilla and mandible, we use them as the radiographic appliances with a rigid interocclusal index at the proper centricalization position. On the mandibular arch, a surgical template was created using a stereolithography process, and a surgical index was used also so that we can place the mandibular surgical template in the correct position. A prefabricated prosthesis was created in acrylic resin, and the placement of the implants with the restoration in place. This is the patient number 7 before, and this is a patient after placement of the implants on the mandibular arch. A year later, the maxillary arch was then treated with a titanium framework for the maxillary arch, and using Noble Guide and Noble Guide surgical templates. The titanium framework was prefabricated and the prosthesis prefabricated prior to implant placement. A new surgical index was created based upon that centric relation position of the mandibular arch to the maxilla. That was cross-mounted in the laboratory. The surgical procedure that we used was insertion of the surgical template, making sure that everything was passively fitting. And we had 3 stabilization pins to hold or anchor that surgical template in the correct interocclusal record. After placement of those stabilization pins, the patient was allowed to open, giving access to the surgical sites. The original protocol was to use a start drill, so that it was a soft tissue punch and countersink drill, and the first implant position was one before the most distal implant placed. A 2mm twist drill was used, a 3mm twist drill, and then implant placement with a guide on an implant mount to give us our XY, and then as the implant mount bottomed out onto the surgical template, gave us now our Z-axis. After the first implant was placed, the surgical template abutment was inserted. This template abutment allowed for holding the position of the surgical template to that very first implant placed. It's an expansion abutment that prevented the surgical template removal as well as further compression of the soft tissue. After this was placed, the second implant was placed on the opposite side. As stated earlier in the program today, I suggest placement of the 2 implants at the same time, not separately, so that there is no torquing of the surgical template. But this is what was done initially. After the 2 implants were placed, the remaining implants were placed almost in a cookbook fashion. Soft tissue punch, countersink, 2mm twist drill, 3mm twist drill, and then implant placement. The implants that were used here were the Branamark Mark IIIs with a tyenite surface, and they were 4.0mm diameter implants. This was the 1-week post-op of this patient in the maxilla, and 3-month post-op radiographic data of where the implants were placed, the height of the bone with that titanium prosthesis. But after about 3 years of the patient, wear of the prosthesis occlusally, we then started to see delamination of the teeth and fracture of the teeth. This patient fractured the lateral incisor, delaminated the central incisor, and multiple issues with the prosthesis. And that is when we decided to actually begin the process to remake the prosthesis. We made the prosthesis on the mandibular arch in a titanium framework with acrylic resin teeth. And in the maxillary arch, we did a little something different, and that was to use a zirconia framework. This actually was a resin scanning index that we were able to try into the patient and evaluate tooth positions, incisal edge positions, and the occlusion. We then cut back this acrylic resin scanning appliance to make space for the veneer and porcelain. But we left all the occlusal surfaces and the first molars in a solid zirconia position, where the occluding surfaces were all in 100% zirconia. This is the framework in the intaglio surface, the soft tissue contact, and try-in of the patient, where we not only tried in for passivity of fit, but also looking at the occlusion and any changes in the occlusion and adjustments that were necessary. This is the radiograph of the fit of that prosthesis and the try-in of the zirconia framework. What is interesting to note is the amount of bone that is around this patient from that immediate lobe prosthesis, and the height of bone around each one of those implants through this guided procedure. This is the patient with the veneering porcelain placed, and you can see the solid zirconia molars. This is the occlusal surface with the thin veneering porcelain that was used for creating the aesthetics. And our prosthesis in place, a all zirconia maxillary prosthesis direct to the implants, and the metal and resin, or titanium and acrylic resin, fixed complete denture on the mandibular arch. We did this protocol knowing that where we would have to replace that mandibular arch or the denture teeth, rather than having the common materials and having to replace both arches, know that we would just have to replace one arch. Again, taking our patient from before through to the definitive prosthesis 8 years later with her smile and prosthesis in place. This was actually submitted as a clinical report and 8-year follow-up of this patient by Dr. Moy and myself, and will be released for publication this year. But what is interesting is the quantity of bone of this prosthesis with the immediate lobe restoration, and 8 years later where the bone levels are. 3 months after implant placement on the 2003 to where it is today in 2011. But the biggest issue with all of the patients that we have treated was the occlusal wear. How much wear these patients had with these prostheses long term, which brings up a question of what materials do we use for these patients? And what is the availability, or what materials are available to treat our patients? Well, we can first look at all acrylic resin prostheses. We really need to consider these as provisional restorations or transitional restorations. And when using these acrylic resin restorations, using the temporary cylinders in metal, such as titanium, to the implant interface so that we know that they're fitting well and passively. The other option is the carbon fiber frameworks that we had been using initially. We did find that they worked well, they didn't fracture, but it's still acrylic resin around that framework. So therefore, we really need to consider these transitional prostheses. We had issues of fractures of the veneering acrylic resin, but most importantly, these are not commercially available in the US. There is also metal and resin fixed complete dentures, typically completed in cast gold to the frameworks and having acrylic resin wrapped around the frameworks in multiple designs. But today, I think to prevent errors of casting procedures, CAD/CAM titanium frameworks becomes the norm, and wrapping the design of the acrylic resin around these frameworks, or how do you design the frameworks to support the acrylic resin teeth and denture base. But we know that these materials do also wear, and that patients should understand that they do wear and need replacement of denture teeth periodically. The other is metal ceramic type restorations, or metal ceramic fixed complete dentures, typically cast gold and a feldspathic porcelain or veneering porcelain placed over the gold in these cast frameworks. We can also make CAD/CAM titanium frameworks where we can actually create tooth preparations on the frameworks. Here it is in a resin before milling, and this is actually milled titanium framework that can then be prepared more precisely, and then having a superstructure that is cemented or tapped to place or retained with lingual set screws to have access back to these areas. These types of crowns can be done in numerous materials such as metal ceramic, zirconia, or can be used with different pressed ceramic systems as well to fit onto the titanium framework. This is cast metal with a composite resin, highly filled composite resin in gingival colors in these restorations in the maxilla. And then today, as shown earlier, we can also look at zirconia frameworks. Zirconia frameworks have many benefits, but also many complications because it is porcelain. They can fracture, and we can have veneering porcelain fractures. Or do we look at these as solid zirconia frameworks? There are many reports in the literature of these types of materials or these types of devices, but without any long-term data. But these are the options for our patients, and as our patients understand that there is not one optimum material, but it will depend upon their needs, their desires, and comfort levels. So what have we learned in the last 10 years? There are many things, starting with template suggestions. As we design and plan our implants, remember those studies that regarding to air at the apex of the implant in particular. And we need to plan implant placement and adjust and allow for accuracy and the possibility of air, especially at the apical positions. We need to inspect each one of these surgical templates that are fabricated and consider making little inspection windows to make sure that the surgical templates are properly seating on the patient, where it is on the cast as well as on the patient. Always try in the surgical templates also. If they're made on the cast, try them in beforehand. Make sure that they properly fitted and seated, or try them on the patient before the surgery. It is suggested because we want to make sure that everything is seated properly. Remember that the position of the patient and the radiographic templates during the CAT scan, as we need to repeat that position or duplicate that position in that surgical template. Make sure that it is in the same position. With these templates, we're also able to, if they are tooth-borne, not soft tissue-borne, we can make small flaps. And so therefore we can watch and see and look at implant osteotomies and implant placement. But we can't alter these surgical templates to allow for this. Have rigid fixations of these surgical templates. We want to make sure that they are stable and they fit well. And so therefore it is suggested that we make very accurate impressions to fabricate radiographic templates or as a scanning cast for our patients or directly in the mouth and intraoral scanning. We want to be able to have accurate representation of the patient in that device to create that surgical template, whether it is impressions to fabricate a radiographic template or impressions to scan for surgical templates. Prosthetic suggestions. In the complete dentures or complete arches, it is crucial that the initial denture that is being used as the radiographic template or the duplicate dentures that are used in the radiographic template are accurate. We want a good fit into the intaglial surface. Well-made dentures with good centric relation stops, because an accurate interocclusal record needs to be made. We want to have even stops on the interocclusal index, nicely spread throughout the arch, because we do not want to have any premature contact. Any premature contacts will create slips and slides of the dentures prosthesis and therefore an inability to replicate these positions back onto the patient with the surgical template. When planning these restorations, there is also the need to understand angulation, especially in the maxilla. As the maxilla resorbs, we have different angulations of these implants and draw of the prosthesis. Check the angulations for draw and making sure that we can have passivity of fit of these prostheses. Also remember that when we're working with the completely edentulous arch, we have to fabricate a cast from the surgical template so that we can transfer the mounted positions of the patients and create a surgical index for the surgical template. This can only be done in the laboratory. It cannot be done on the patient because the position of the radiographic template and the position of the surgical template must coincide. There's also multiple different studies about cross-arch splinting, and there are studies about splinting the implants and not splinting the implants. But with the results that we are having with guided surgeries, one-piece restorations with cross-arch stabilization and immediate loading, I think that is something to really look at, although there are differences in the literature. But we've had great success rates with cross-arch splinting. Surgical suggestions. Confirm the seat of the surgical template. Try it in before. Make sure that these surgical templates are in the right positions. That surgical index is crucial that was made in the laboratory, and the fit of these surgical templates. Did you have a calibration tool? Are these templates the right size? Is the surgical template and the radiographic template coinciding in position? Placement of the implants. We want to remember not to over-torque the implants. Which implants do we place in first? One before the most distal implants. but place 2 of the implants in at the same time using a template abutment to make sure that the surgical template does not torque, as well as once you seat the implant and it touches the surgical template, that is the position in the Z-axis that was planned on the computer in the software. If you over torque it, you'll have soft tissue compression and changes in the Z-axis, not only of that implant, but all the other implants as well. Because guided surgery and the protocols have a very precise osteotomy, we suggest the use of screw taps so that the implants will have better guidance with that screw tap versus placement of the implants on its own. We can have directional changes if you have a end cutting implant, or it can track in different positions. I believe that we should never remove the surgical template once the surgery has started. If you created the osteotomies and you remove the surgical template, you'll never get the surgical template in the same position. Because of swelling of the soft tissue, cutting of the soft tissue, having remove a surgical template, you will not get that surgical template back in the same position. If you are placing an immediate provisional restoration, I do suggest that you clean around each implant. Use a soft tissue punch, clean the soft tissue, as well as use a bone mill depending upon where the head of the implant is in relationship to the crestal bone. Is there enough room for that prosthesis to seat all the way down? Clean around each implant after placement. So there are multiple things that we have learned in these last 10 years about guided surgeries, what we've learned about the use of cone beam CTs and the surgical planning software. There may be multiple disadvantages of guided surgery, such as longer treatment times, bulky instrumentations, costs, but truly the advantages of guided surgery, the precision of understanding that landmarks, precision of implant placement, and the restorative procedures, and the knowledge that we gain from that cone beam CT is such an advantage for us with placement of these implants and for our patients. And so therefore, guided surgery is a must, and looking at what cone beam CTs can do for us for accuracy of implant placement. Thank you very much.